Hello, my name is Pascaline Moffor. Today I'm going to talk about sofosbuvir and velpastatavir for HCV in patients with decompensated cirrhosis. A little bit of background. As the population that is infected with the Hep C virus ages, the number of patients with decompensated cirrhosis is expected to increase. The research was funded by Gilead Sciences. The objective. The trial involved both previously treated and untreated patients infected with Hep C genotype 1-6 who had decompensated liver cirrhosis. The trial design. It was a phase 3 multi-center random open-label study. The location was approximately 40 cities in the United States. The study was approved by the Institutional Review Board or Independent Ethics Committee at each participating site and was conducted in compliance with the Declaration of Helsinki, Good Clinical Practice Guideline, and local regulatory requirement. The inclusion criteria. The ages were from 18 years of age or older with chronic Hep C infection of any genotype and decompensated cirrhosis, classified as Class B, and had a score of 7 to 9 on the scale ranging from 5 to 15, with higher values indicating more advanced liver disease. Then the exclusion criteria. Patients who had undergone liver transplantation were not eligible. Pregnant women were not, since one of the medication can cause teratogenic side effect. And patients who were on medications like blood transfusion, etc., were not included. Subjects. Approximately 150 chronic Hep C infected male and non-pregnant female subjects were selected. Ages 18 years or older with CPT Class B cirrhosis who had not undergone a liver transplant. So the primary endpoint. The primary efficacy endpoint was the rate of sustained virologic response, defined as HCV RNA less than 15 IU per millimeter at 12 weeks after the end of treatment in all patients who underwent randomization and received at least one dose of study drug. The secondary endpoint. Secondary efficacy endpoint included the change from baseline in the CPT and MLD score at 12 weeks after end of treatment. And they had a follow-up. In this multi-center open-label trial, patients were randomly assigned in a ratio of 1:1:1:1:1 ratio to receive a fixed dose combination tablet containing 400 milligrams of sofosbuvir and 100 milligrams of velpastatavir, administered orally once daily for 12 weeks. And the second group was sofosbuvir, velpastatavir plus ribavirin once daily for 12 weeks. And the third group was given sofosbuvir, velpastavril once daily for 24 weeks. Ribavirin was administered orally with food twice a day, with the dose determined according to body weight. So 100 milligram daily in patient with a body weight less than 75 kilograms, and 1200 milligrams daily for patient with a body weight above or equal 75 kilograms. And there was a randomization according to the HCV genotype. The population involved, they had 438 patients who were screened. The arms, so the statistical analysis in the primary efficacy hypothesis, they compared the rate of sustained virologic response in each of the 3 treatment groups with an assumed spontaneous rate of 1% using the two-sided exact one sample binomial test with Bonferrini alpha adjustment. They determined that the enrollment of 75 patients in each treatment group would provide a power of 99% to dictate an improvement of at least 40% point in the rate of sustained virologic response over the assumed spontaneous rate of 1% using two-sided exact one sample binomial test at a significance level of 0.0167. They calculated the end point estimate and two-sided 95% exact confidence interval that was based on the clopidogrel method for rate sustained virologic response for the 3 treatment groups combined, as well as according to the Hep C genotype and subgroups. The study was not designed or powered to detect significant differences in rates of sustained virologic response among the treatment group. However, they perform at least an ad hoc pairs way comparison of rate of sustained virologic response among the 3 treatment groups, for which they calculated the points estimate corresponding to 98.3% confidence interval rather than 95, owing to the 3 pairwise performance pre-specific analysis of changes in CPT and MLD score from the baseline to post-treatment week 12. The analysis of the change in the MLD score was performed separately from patients with baseline score of less than 15 and those with the baseline score of 15 or more. The baseline characteristics of the 438 patients who were screened, 268 underwent randomized and 267 began the treatment. The demographic and baseline clinical characteristics of patients were generally well balanced. Overall, 60% of patients had Hep C genotype 1A, 18 genotype 1B, and 4% genotype 2, 15% had genotype 3, and 3% genotype 4, and less than 1% had genotype 6. No patient had genotype 5. A total of 6% of the patients were Black, and 55 had received prior treatment for Hep C infection. So the treatment with the fixed dose combination tablet of sofosbuvir, velpastavril, with or without ribavirin for 12 weeks, and with sofosbuvir, Velpastavi for 24 weeks resulted in a high rate of sustained virologic response and early improvement in hep C function in patients with decompensated liver cirrhosis caused by hep C of all genotypes. So for adverse effect, the most common adverse event in all groups were fatigue, they had 29%, nausea 23%, and headache 22%, although anemia, diarrhea, and insomnia were also amongst patients who received sofosbuvir, velpastavi plus ribavirin. Overall, 81% of the patients in the group who received sofosbuvir and velpastavi alone had at least one adverse effect, as compared to 91% of patients receiving sofosbuvir, velpastavi plus ribavirin. So, what was the author's conclusion? The author concluded that the treatment with sofosbuvir, velpastavi with or without ribavirin for 12 weeks and sofosbuvir, velpastavi for 24 weeks resulted in higher rate of sustained virologic response in patients with hep C infection and decompensated liver cirrhosis. The strength. The results are in line with those of other recent trials of direct-acting antiviral regimen in the SOLAR-1 and SOLAR-2 trial. Patients with genotype 104 and CPT class B or C cirrhosis who receive levetiracetam, sofosbuvir plus ribavirin for 12 or 24 weeks had rates of sustained virologic response of 86 to 89% at 12 weeks after the end of treatment. In the phase 3 early 1 trial, 12 weeks of treatment with daclexavid, sofosbuvir, and ribavirin resulted in a sustained virologic response rate of 82% in patients with hep C genotype 1 and liver cirrhosis. The weaknesses. This study had several limitations. It was not powered to detect significant differences among the 3 treatment groups. They enrolled only patients with moderate hep C decompensation, so the results cannot be generalized to patients with more severe liver disease. Also, the number of patients with hep C2 genotype with the genotype 2, 4, or 6 were too small to allow any conclusions to be drawn about the efficacy of sofosbuvir, velpastavi amongst patients with this genotype. Enrollment was limited to the United States, which may account for the high proportion of patients with hep C genotype 1. Summary of primary literature. This was a 3-phase open-label study involving both previously treated and untreated patients infected with hep C genotype 1 through 6 who had decompensated liver cirrhosis. Patients were randomly assigned to 3 different groups, and they were given treatment for 12 weeks and 24 weeks. So the conclusion. In my opinion, this study had a lot of limitations from the get-go. It had 3 treatment groups, which makes it difficult to manage. The fact that they only enrolled participants from the United States with moderate liver disease created a very big gap for inconsistency with the assessment. They also had some time constraint issue. I believe that if they had conducted the study for a longer period of time, the study would have had more comparative data to draw more accurate conclusions from. Thank you.